Beware of immune checkpoint inhibitor toxicity in GI, liver and others by Dr. Aniket Goenka. I will request the chairpersons to join us on the dais. Dr. R.S. Chachra, Senior Gastroenterologist in Bhopal. Dr. Shohini Sirkar, Senior Gastroenterologist, Choitram Hospitals, Indore. Dr. Vijay Bhargav, Consultant Medical Oncologist at JLN Cancer Hospital, Bhopal. And Dr. Arun Singh Bhadoria, Gastroenterologist at Medanta Hospital, Indore. Thank you.
At the outset, I would like to thank Dr. Sanjay Kumar for giving me the opportunity to be part of this academic feast. And with all feast, it ends on a sweet note. So I'd like to keep, I'll promise I'll keep it short and sweet. The topic is immune checkpoint inhibitor toxicity. What I'll discuss today is introduction to checkpoint inhibitors, mechanism of action, toxicity spectrum, kinetics of toxicity, mechanism of toxicity, the role of GI physicians, and the Indian data on it. Immune checkpoint inhibitors are molecules that utilize the immune cells of the body to act on cancer. Cancer has developed checkpoints and breaks on this immune cell activity so as to prevent its action, while these checkpoint inhibitors remove this blockade on immunity. At present, there are more than 5,000 studies being conducted on immune checkpoint inhibitors alone or in combination. Initially, these molecules showed exceptional response in melanoma, but are now used in many more diseases. This is from 2019 data from United States. More than 40% of all cancer patients were eligible to receive immune checkpoint inhibitors. As with all drugs in malignancy, initially they are utilized in metastatic setting, and then if they are successful, they move on to adjuvant and neoadjuvant setting. And here we can see that immune checkpoint inhibitors have moved on to neoadjuvant settings as well. For the GI physician audience, we all know that in microsatellite inhibitor, high colon cancer, we are using neoadjuvant immunotherapy as well. If you look at the mechanism of action, the immune checkpoints are PD-L1, PD-1 interaction and the CTLA4 and B7-1 interaction. If you look at the PD-1 inhibitors, it is nivolumab, pembrolizumab, while if you look at the PD-L1 inhibitors, it is atezolizumab and evolumab, while CTLA4 inhibitors are ipilimumab and tremelimumab. These are the molecules which act on these immune checkpoint blockades. If you look at the spectrum of immune checkpoint inhibitor toxicity, it affects almost all organs, systems. It affects from the brain to the gut, from the muscles to the lungs. It affects endocrine system and musculoskeletal system, all alike. If you look at the mechanism of toxicity, immune checkpoint inhibitors increases T cell activity against antigens that are present in tumors as well as healthy tissues. This results in immune activity against normal organ systems. Especially, this is the reason why myocarditis happens. This is what we call the on-target effect of immune checkpoint inhibition. Immune checkpoint inhibition also results in increase in levels of pre-existing antibodies, which causes the thyroiditis which is seen in checkpoint inhibitor toxicity. Activated T cells and cytokines lead to inflammatory bowel disease, and CTLA4 antibodies present on pituitary and can lead to pituitary dysfunction and hypophosphatitis. So if we look at the kinetics of toxicity, the time of onset of toxicity is usually predetermined. This is with PD-1 inhibitors, skin and gut toxicity is seen in 3rd or 4th week. Hepatic and endocrine toxicity is seen typically in 6th to 7th week, while neurological toxicity is seen in 7th to 8th, lung in 9th to 10th, and at the end, renal toxicities with 14th to 15th week. of starting therapy. If you look at the resolution kinetics of toxicity, we see that the GI toxicities are resolved within a week or two, and that's why probably if the GI toxicity is not resolved within a week, we prefer aggressive management of GI toxicities. Here we can also see hepatic toxicity gets resolved within 3 weeks, while skin toxicity can persist for a median of 18 weeks as well. Now the toxicity profile of each drug is different, and immune checkpoint inhibitors is just a broad term. So if we look at the toxicity profile of ipilimumab, we see a lot of gastrointestinal and renal toxicity, while for atezolizumab it is more hypothyroidism, and with nivolumab we have more endocrine toxicities. If you look at the relationship of severity and incidence of toxicity, myocarditis and neurologic toxicity with encephalitis are usually fatal and life-threatening, but also less in incidence, while hepatitis, colitis, and pneumonitis lie somewhere in the mid-range in incidence, while rash and arthralgia are high in incidence but less in fatality. So if we look at the spectrum of only fatal toxicities, colitis, pneumonitis, and hepatitis are the most important toxicities seen, especially with CTLA4 antibodies, that is ipilimumab and tremelimumab. Colitis can be as high as 70%, leading to all fatal toxicities. While if we are using combinations of PD-1 inhibitors, it contributes 37%, and hepatitis a good 22%. So if we look at the principles of immune checkpoint inhibitor toxicity management, these 5 sub-steps are important: prevention, anticipation, detection, treatment, and monitoring. What we mean by prevention is to know the immunity toxicity spectrum, is to identify these and to manage patients and to make the patients and healthcare provider aware about it. If you look at the anticipation, we need to ensure that blood tests are done routinely, detection based on symptoms and signs, treatment on the basis of the severity with immunosuppression, and most importantly involvement of organ specialists, and ensuring that the resolution of symptom follows the typical resolution kinetics. It is seen that patients who have a history of autoimmune disorders have a higher risk of developing toxicity. Comorbidities should be mentioned as they can lead to organ compromise. In anticipation of toxicity, we need to ensure that baseline blood tests are done, and some blood tests are routinely done after every cycle. For detection, we need to be aware about the signs and symptoms of fatigue, rash, diarrhea, hepatic dysfunction, hypothyroidism, pneumonitis. And for treatment, we need to be, as a rule of thumb, this is grade 1, grade 2, grade 3, grade 4. Grade 1 needs symptomatic management. Grade 2, we need to stop the drug and start oral steroids. Grade 3, severe, it should involve a specialist, the organ system specialist, and grade 3 and 4 needs to be treated aggressively. Here, I would like to point out that teamwork is of essence, with organ specialists to be involved in management of checkpoint inhibitor toxicity. So why GI physicians are important in management of immune checkpoint inhibitor toxicity? Gut is a lymphocyte-rich area, hence higher incidence of gut involvement with immune checkpoint inhibitor toxicity. There are no phase 3 data on randomized data on management of toxicity of immune checkpoint inhibitor. All the learning of management of immune checkpoint inhibitor is based on IBD management. Earlier toxicity is seen in gut and skin. Most life-threatening toxicities are colitis, pneumonitis, and hepatitis, while latent viral hepatitis B activation can also complicate management of immune checkpoint inhibitors. So I am speaking to an audience of gastrophysicians, so I would spend a little less time in management. But a rule of thumb, grade 1 to be treated with symptomatic management, grade 2 we need to withhold the drug, treat with oral steroids, grade 3 and 4 IV steroids and infliximab in cases of diarrhea. An important point to be noted is that not all diarrhea is colitis and not all colitis will present with diarrhea. Colitis is defined on the basis of colonoscopy, it is defined on the basis of imaging, it is defined on the basis of stool calprotectin levels. Hepatitis management, again similar, with grade 1 being managed symptomatically, grade 2, grade 3, and then grade 4 involving other immunosuppressants as well with mycophenolate mofetil. So is toxicity always a bad thing? Here if we see the Kaplan-Meier curves of survival, the blue curve represents the patients who developed 2 toxicities, while the yellow curve represents patients who developed at least 1 toxicity, and the purple curve represents the patients who did not develop toxicity. And here we can see that the patients who developed toxicity had better survival. Not all toxicities are associated with better prognosis. Pulmonary toxicity is associated with poor prognosis. So if a patient develops grade 1, grade 2 toxicity with checkpoint inhibition, we can be happy if we are able to manage them properly. We use steroids to treat immune checkpoint inhibitor toxicity, and since steroid causes immunosuppression, there is a thought that providing immunosuppression to a patient who is on checkpoint inhibitor, would that lead to inferior survival? But that is not the case, as we can see here that the Kaplan-Meier curves are coinciding with each other, whether they have received systemic steroids or not. We have commonly seen that PPIs are prescribed in almost all prescriptions, and this is an important aspect, that there are studies which have shown that PPI use results in less survival and is associated with poorer survival as compared to those patients who are not exposed to proton pump inhibitors. So proton pump inhibitors should not be routinely prescribed. Some important aspects about immune checkpoint inhibitors is that live vaccinations need to be avoided. We can do killed vaccinations. Breastfeeding to be avoided for at least 5 months after the last dose of immune checkpoint inhibitors. Contraceptives are to be used for at least 5 months of the last dose of immune checkpoint inhibitors. And we need to keep in mind about autoimmune conditions of the patient, drug interactions, and infectious disease screening. At the end, I would like to present some Indian data. This is from Tata Memorial Hospital by Dr. Vanita Norona et al. She presented a data of 155 patients. In her case series, it was there were the incidence of immune-related adverse events was less than 10%. And this is the data that we presented at IOC-Con. And here, in our data of 86 patients, the total toxicity was around 14%. So checkpoint inhibitors are not associated with very severe toxicities, but it can be fatal. So a few take-home points. We need to prevent checkpoint inhibitor toxicity. We need to screen for autoimmune diseases, know about comorbidities, and avoid routine use of proton pump inhibitors. We need to anticipate with regular testing of T3, T4, TSH, and other battery of tests. We need to detect, keep our antennas up for signs and symptoms. An important aspect is colitis is not diarrhea. It needs to be identified on the basis of symptoms and colonoscopy or imaging. Steroid use does not affect the efficacy of these molecules, so it can be used liberally. Interdisciplinary management is something of paramount importance in management of checkpoint inhibitor toxicity. And another important point, patients who develop toxicity do better. Thank you.